Oh, wow. Sorry, I
Oh,
just
there it
looked
is.
at the
Okay.
chat.
How do I come back and forth?
Welcome, everybody.
I just want you to see the chat. Look, Vincent from Germany.
Awesome.
Wow.
Welcome. Welcome, everyone. This is so exciting to see everybody joining us from all around the world. Good morning. My name is Adrienne Griffin. I see somebody from Rochester, New York. Yay, that's the area of the world that I'm from. So great to see so many people. Thank you for joining our webinar today on improving maternal mental health for military mothers. This is a 2-hour webinar, so I hope you've gotten your lunch or your bottle of water and you're ready to be with us for these 2 full hours. We are joined by some terrific panelists today, so we are just going to get started. Again, my name is Adrienne Griffin. I'm the Executive Director of Maternal Mental Health Leadership Alliance. And we are hosting this webinar today in partnership with our great friends from Postpartum Support International, as well as PSI's Alliance for People of Color, and Humana Military and TriWest, which are the 2 insurance companies that provide healthcare to our nation's military families. So we're going to drop a quick poll in just to get some information from all of you in our studio audience. Which category best describes what you do? This way we can just get a quick summary of who is in the audience, and then we can follow up with you. So just click one of those little buttons, and then we will move on. All right, so while that poll is still going, I'm just going to get started with the rest of the slides. So most of you have been using Zoom for a while, and so you know all about how to use the Q&A button to ask a question. Go ahead and drop information in the chat about yourself, which lots of people are already doing. And then there's, of course, buttons to show captions if you need them, and reactions to share an emoji. So after this webinar, we will email you a brief survey to get your feedback. We are recording this webinar, so of course we will share the webinar link as well as the presentation slides, and then whatever additional information that we might identify during the course of this webinar. For example, there is another longer version of this information being shared on November 14th through TriCare, and so that's the kind of information that we'll include in that follow-up email. So a quick look at Maternal Mental Health Leadership Alliance. There's our terrific team. We are a small but mighty nonprofit focused on national efforts to improve maternal mental health in the United States through advocating for change, building partnerships, and curating information for the field of maternal mental health. As I mentioned, there will be an upcoming fall symposium, a full-day presentation that includes continuing education units, and we'll share that information when the registration is live. So today, what we're really focused on is taking the group of mental health providers or maternal child healthcare providers. We know that some know about the military environment and some know about maternal mental health. Right now, we have kind of a small overlap of those 2 groups. And what we're doing over the next, with this session and other learning sessions, is to increase that overlap so that we have more mental health providers who know about maternal mental health, as well as the nuances of working with moms in the military setting. So how are we going to do that? Here's our agenda for today. Just a minute or 2 about why this topic and why now. And then a quick overview, not a quick overview, I'm sorry, an in-depth presentation on Maternal Mental Health 101, and then a discussion of unique factors that impact military mothers. And then we will hear from our 2 TRICARE providers about how to join the TRICARE network so that if you want to work with military families, you can do so. So I have a terrific lineup of speakers today. Patience Riley, who is representing the Alliance for People of Color. She will introduce more about herself. All of the speakers will introduce more about themselves, but Patience is a mom, an Air Force spouse. She grew up in the military. She's a therapist. She has been working with military families for a long time and will have some great insights. Bertie Gunyon-Meyer is the Director of Education and Training for Postpartum Support International and will be giving us the presentation about maternal mental health. And then Chris Taylor from Humana Military and Jackie Bush from TriWest Healthcare Alliance will talk about how to become paneled with their 2 companies so that you can work with military families. All right, so why this topic? Why now? Well, we've learned over the last several years is that mental health conditions are the most common complication of pregnancy and childbirth and a leading cause of maternal mortality. We also know that more women are serving in the armed forces than ever before. 230,000 women are on active duty. That makes up 17% of the active duty force. And we also know that military mothers are at increased risk for experiencing maternal mental health conditions. And this is across all spectrums. So not only active duty, but their spouses and dependents, retirees, veterans. And these women experience maternal mental health conditions at 2 to 3 times the rate of their civilian counterparts, in part because of the unique lifestyle and cultural issues of being in the military. We also know that there's significant racial considerations. We know that Black women make up nearly 30% of women in the military, and this is twice the representation in the civilian population. We also know that women of color experience higher rates of health complications such as severe maternal morbidity. So we have more women of color, and we know they experience these conditions at higher rates. So we want to make sure that we're paying attention specifically to our women of color. And again, as I said earlier, all military mothers are at increased risk for maternal mental health conditions. This is information from a GAO report that shows every single group, retirees, active duty, dependents, reservists, all experience maternal mental health conditions at significantly higher rates than the 1 in 5 that we see in the civilian population. So when we look at the number of military mothers who give birth each year, we see that there are about 110,000 military families who welcome a baby each year. That's across active duty, beneficiaries, and veterans. And so when we run the numbers, we see that about 40,000 military families are impacted by maternal mental health conditions each year. And we know this impacts not just the mother, the baby, the spouse, and the family, but also military units and force readiness. So this is a significant issue, and it's something that we can actually take action and do something about. So there are the sources for all of the information that I shared. And now I am going to pass the microphone to Bertie Gunyon-Meyer, who is the Director of Education and Training for Postpartum Support International, to teach us all about maternal mental health. Thanks, Bertie, for joining us, and the microphone is now yours.
All righty. Thanks, Adrian. So you're going to hear me give you an overview of perinatal mental health in 40 minutes. So how about that? Let's go back one second. I got click happy. So for those who don't know me, I am a nurse. I'm also a therapist, and I am certified in perinatal mental health, which I see some of you here are too. And I am currently the Director of Education and Training with Postpartum Support International. I did, with a team of subject matter experts, set up a certification in perinatal mental health. I am a past president, which now we call it the chair, not the president. But anyway, I'm a past president. I am also certified in lactation counseling and childbirth educator, perinatal bereavement. I'm on the Maternal Mortality Review Committee for Indiana, and I know some of you are on that too. I did work at a hospital for a million years, Indiana University Health, and I specifically work from home remotely in Speedway, Indiana, where the Indianapolis 500 is held, the greatest spectacle in racing. So let's get going. 1 in 5 to 7 women, 1 in 10 men will get a perinatal mood disorder. And so that means I have this picture to remind you, trigger warning. This could bring up feelings. Um, so know that right now, because I know that many of you. Why do we care about it? Because it's the number one medical complication related to childbearing. It's an opportunity to help women and their partners and their families with prior undiagnosed. You should know your own diagnosis. There is the point right there. We none of us have a clean history. We inherit what we inherit. And so sometimes when people come in for postpartum depression, postpartum anxiety, it's the first time they've really realized their own previous diagnosis. Illness is detectable. That's why we care about it. Shouldn't have to suffer. So, what are the risks when we don't treat it? Relationship problems, poor adherence to medical care, exacerbation of other medical conditions, IPV, separation, divorce, loss of money. Gosh, it costs more money. And disability, unemployment, child neglect and abuse, developmental delays, behavioral problems, more nicotine, more alcohol, more substance use. And the very worst of all, infanticide, homicide, and suicide. That's why we care about this. Data from the maternal mortality review committees. This was in 36 states, and this information came out from 2000, taking a compilation of 2017 to 19 in 36 states. What did we find out? Number one reason for maternal mortality is mental health. Right there with it, substance use disorder. Sometimes accident overdose, sometimes on purpose. And this is really something we didn't even track prior to like 2000, whatever, I don't remember what year, but we were constantly talking about medical issues for maternal mortality reasons. And I can still remember back in the day at my hospital, hey, wait a minute, what about mental health? I don't know. They don't talk about that. Well, look, my head's attached to my body. Funny thing, why is it we're comfortable treating my blood pressure, my diabetes, but we're not comfortable talking about this? And we need to be. It's underdiagnosed and undertreated. We don't even find half of the women with a perinatal mood disorder. And then when we do find them, look how many come to get help. Very low numbers. Why is that? Because we hand them a card and say, call Birdie. They have phone anxiety. They don't make the call. They think this is just going to go away. Um, or we hand them a 10-page piece of paper and says, here's who takes your insurance. And the first three places they call say, we're not taking new patients. So they give up, or they just think, oh, I'll just wait. This is embarrassing. So, depression and anxiety can occur anytime during pregnancy or in the first year postpartum. You'll hear us call it perinatal mood and anxiety disorders. You'll hear us call it perinatal mood disorders. You'll hear us call it perinatal mental health. You'll hear us call it maternal mental health. You're going to hear different terms. It's all the same, but your patients, your clients, if they're Googling help, they're going to Google postpartum depression. So the prevalence, baby blues, affects 80% of new mothers. 1 in 5 to 7 mothers will experience serious depression or anxiety. 1 to 2 in 1,000 will experience psychosis, and 1 in 10 fathers. So these are just some overall numbers that you'll hear me mention again. The myths about postpartum depression is when we say postpartum depression, it means it's only in the postpartum period and it's only depression. What have we taught for years? If you find yourself crying a lot, be sure and call your doctor. Well, what if I wake up mean as a snake, yelling at my toddler, yelling at my spouse? You didn't tell me to watch for that. What if I'm anxious, jumping out of my skin? You didn't tell me it could look like that. So it's not all about crying. And some people, if you say postpartum depression, think, oh, that means those are the people that want to harm their baby. Or those are the people who don't love their baby. And the truth is, not everyone falls madly in love with their baby right away. But we hear on the news things like Andrea Yates drowned her 5 children, and that was back in 2001. And we've heard other awful stories since then. And the news puts it out and says they think it was postpartum depression, postpartum depression. So then people walk around saying, oh, I don't have that. So it's very confusing. And because we say postpartum, it means, oh, you're going to be fine during pregnancy. No, not true. It could start during pregnancy. And I've already talked about my head being attached to my body, so don't forget that. So let's look at the many faces, the meat of what I want you to know. What does this look like? This can be depression, anxiety, panic, OCD, PTSD, psychosis, or bipolar. These disorders can affect us at any time in our lives, but during pregnancy and postpartum, they are ramped up and they look different and feel different. Like you already had anxiety, now you're anxious about a baby. So let's talk about what this all looks like. Catherine Wisner and others did a study of 10,000 women, biggest study to date, found out 21.9% had postpartum depression. So some of those came into pregnancy with already having depression or anxiety. 33% developed a perinatal mood disorder during pregnancy, and 40% developed it in the postpartum period when they carried it out to 1 year. That's where we get our 1 in 5 to 7. And of this, what was the diagnosis? 68% had unipolar depression or just plain old depression. 66% had anxiety. What you might see is the presenting factor, someone just with anxiety. Or you might see depression and anxiety hanging out together. They like to hang out together. 22% of these women were diagnosed with bipolar disorder, and 19% endorsed thoughts of harming themselves. Keep in mind that most studies were done on white heterosexual couples until about 10 years ago. So, pointing out when we say women, the studies were done on women. We say men, the studies were done on men. Just want to point that out. The blues, overall mood is happiness. This is your first teaching point that you're teaching your patients. The blues only last 2 weeks. If it's beyond 2 weeks and you still don't feel like yourself, then you need to call. You need to call me back. And then have your office and all your staff clued into that, that when they call, please pay attention to that. So it peaks at 3 to 5 days. When we're pregnant, estrogen and progesterone, high as they're ever going to be. When we deliver, they crash down. Up come oxytocin, prolactin, brings in the love hormone, brings in your milk. But that's what causes baby blues. And people will say, well, I had the baby blues for 6 months. Well, actually, no, you didn't. Baby blues last 2 weeks, and it's because of hormone changes. So, overall mood happiness, your first teaching point, don't forget, 2 teaching points, 1 in 5 to 7 women, 1 in 10 men. It doesn't last more than 2 weeks. Baby blues don't last more than 2 weeks. You're really emphasizing that. Call us. So, depression, just what you know it is: sadness, crying, unexplained physical complaints. Maybe they'll say they're nauseous, diarrhea, vomiting. Typically, let's say typical um, overeating, junk food, sugar and chocolate, oversleeping, yet still tired, maybe suicidal thoughts. We've got to ask about that. They can't concentrate, they're irritable and angry, and we didn't tell them to watch for that. They feel hopeless and helpless. That's where suicide comes from. I'm never going to be myself again. If I have to be this the rest of my life, then I'd just rather not be here, or they'd all be better off without me. And they're ashamed. They're so ashamed that they have this, as if it's their fault. And we'll talk about why we get it. So they say, I'm overwhelmed. I had no idea it was going to be this hard to be a parent. They take our prenatal classes and we teach them all these fun things, but all they're preparing for is labor and delivery. And then that baby gets in, they're like, I don't have a clue what I'm doing. They maybe aren't falling in love with baby right away. They can't take care of themselves. Loss of interest, joy, or pleasure in usual activities. That's called anhedonia. They might have anxiety with their depression, mood swings, a sense of worthlessness. And they're not waking up and saying, I think I got postpartum depression. They're waking up and saying things like, this doesn't feel like me. Something's not right. I haven't been myself since a baby was born. So we looked at depression. Let's look at anxiety and panic. Anxiety, agitated, can't sit still, excessively concerned about baby's health or their own health. They're calling pediatric office every day. They're worrying they have something. They're on high alert. They aren't eating. They're losing 20 pounds in 2 weeks, and people say, oh, look at you, got your figure back. Nope. That is not what it is. They've got anxiety. You see somebody who lost a bunch of weight in 2 to 3 weeks, think about anxiety. They can't fall asleep. They can't stay asleep. They can't go back to sleep. Don't say, are you sleeping when the baby sleeps? That's like asking, are you doing laundry when the baby does laundry? Ask them this: if the baby slept for 4 hours, would you be able to sleep? That's when the anxious person will say, no, I can't. Why not? Tell me why not. My mind won't shut off. I'm worrying all the time. What if my baby stops breathing? I have to watch her all night. There's too much to do around here. I've got to get the dishes done. They're constantly worrying, racing thoughts, short of breath, heart palpitations. Then they go into full-blown panic attacks sometimes. Extreme anxiety, shortness of breath, chest pain, lips go numb, face goes numb, hands go numb. Excessively worrying, fear, panic may wake them up. They end up in an emergency room thinking they're having a heart attack. And once you've had a panic attack, you panic about having another panic attack. They go to emergency and they get told, nope, this is postpartum anxiety. They describe a panic attack just like this: I thought I was dying. I thought I was going crazy. I thought I was losing control. Okay, depression, anxiety, panic. Now let's look at OCD. When we say to people, you're so OCD, we kind of mean everything's in order, your house is all neat, or you do things in a certain way. Well, that is a certain classic symptom of OCD: cleaning, checking, counting things in a certain order. But OCD can also look this way. I clearly saw my daughter gray and dead under the water. I couldn't give her baths or take her swimming or put her anywhere near a body of water. What kind of mother thinks these things? My daughter would have been better off without me. OCD, an actual diagnosis of OCD, is intrusive, repetitive thoughts, usually of harm coming to baby. They get caught in this what if I drop the baby? What if this? What if that? They're horrified by the thought. So it comes out of the place in your brain that you want to protect your baby. It's taken and twisted and said, what's the worst that's going to happen? And then you have that image, that picture, a movie rolling in your head, an image that all of you have had. You're driving down the highway, you're behind one of those trucks with the cars chained up on it. What's your image? Those cars are all coming off. So that's an intrusive thoughts all of us have. About 88% of new parents have what if thoughts. But if you have a diagnosis of OCD, this is debilitating. It is just literally keeps them from functioning. So don't forget, some of us have intrusive thoughts. Well, most of us do. But when you have a diagnosis of OCD, it's really awful. It plays in their head and they see pictures, images that are really horrific. These are just some of them. What if I drop her? What if I get hit in traffic? What about water? So actually common triggers are water, sharp objects, um, heights, traffic, and even some people have sexual thoughts, and these are just horrifying. So fears of deliberate harm, contamination is big, accidental harm, ordering, arranging, religious checking. So this is the most misunderstood of all the diagnoses. It's the gold standard for treatment is ERP. Please do not engage in ERP or exposure of any kind with a perinatal patient unless you have been trained, supervised, and have had consultants for quite a while. Don't start messing with it just because you read one article on it. So just want to say that is the standard. Thoughts do not equal action. We must ask. You know, sometimes new parents have scary or unusual thoughts. Are you having scary or unusual thoughts? That commonizes it. It makes me be able to say, oh, you know, I keep worrying that my husband's going to get killed and then I'm going to be left all alone to raise this baby. That's a scary thought. But if they have intrusive thoughts, they'll go like this. I can't say it out loud. It's so awful. And you can say, please tell me. They're called intrusive thoughts. Now you're going to go further and ask more questions, and we'll talk about that in a minute. Parent doesn't want to harm the baby. The thought's obsessive, and they've taken steps to protect baby. They won't bathe the baby. They won't drive over a bridge. They lock up all their knives and scissors. They have no delusions or hallucinations. Okay, that's how you know it's OCD and not psychosis. They're in touch with reality. They're having no delusions, not seeing things that aren't there or hearing things that aren't there. High risk, the parent has delusional beliefs. My baby's eyes are glowing. I think he's a demon. That's not an intrusive thought. That is out of touch with reality. I see my baby's eyes glowing. So they may also be scared by the thoughts. So we can't say, oh, if they're scared of the thoughts, then it's OCD intrusive thoughts. No, don't do that. You've got to ask, what is the thought? So just know that about 80% of our clinicians don't know OCD intrusive thoughts and don't recognize it. And therefore, what happens if someone tells their intrusive thought, their clinician calls Child Protective Services, their clinician calls 911, sends them to emergency department, sends them to psych. That's because they're not trained. So we need more people trained. We have OCD support groups. I'm going to brag about all of our support groups in PSI, which are free. So let's look at PTSD. It is something that happened at delivery that was scary, okay? And many, you'll see statistics. The latest I heard is 1 in 2 women say that something traumatic happened at their delivery. An old article from 2004 by Cheryl Beck, nurse researchers. It's in the eye of the beholder. Don't tell me that my birth was not traumatic. It is in my eyes that it was traumatic. It's an event occurring during the labor and delivery process that involves actual or threatened or serious injury or death to mother or her infant. It can be psychological or physical. The birthing person experiences fear, helplessness, loss of control, and horror. Just take a look. I'm not going to read them all. These are some potentially traumatic events. Don't tell someone they had a traumatic birth. It may not hit them that it was traumatic, or it may not even come up till 3 months later. So we don't start right out saying, whoo, you had a real traumatic birth. But these are just some of the things. Don't forget the partner that witnessed it could have PTSD also. And we forget about those poor patients who vomit all through pregnancy 24/7, hyperemesis gravidarum, who have PTSD from their pregnancy. They avoid aftercare. They are angry. They won't go back to the same OB typically. They won't go back to the same hospital. They have sexual dysfunction from a traumatic vaginal birth. They avoid future pregnancies, or it's exacerbated if it's not dealt with. We need to get these women to therapists to deal with the PTSD. Elective C-section in future, or difficulties breastfeeding. Their body's been violated. You touched me. You did things without asking. And at that yearly anniversary of the baby's birthday, they relive that traumatic birth. We have to get some therapy. Also, don't forget 1 in 3 women have been sexually abused. When they come in for their delivery, we're touching them, sticking our hands inside of them, touching their breasts. They may have dissociated from that sexual trauma, and now their body remembers. The body keeps the score. And if you have someone who had previous sexual trauma also comes in and has a traumatic birth, you have got someone with a lot of trauma now to deal with. Any parent who has a baby in NICU, had a stillbirth, um, you can guarantee this is PTSD. So just assume that. Here's just a few websites that helps with some of the things I said. You can get all of these on PSI's website. We also have a support group for birth trauma and resources. We also have a closed Facebook group for maternal near miss. This is someone who almost died or could still die. Let's say amniotic embolism, um, had a stroke, cardiomyopathy, all these things. This is a near miss, meaning they almost died. This is a great moderated by PSI. Know that, as Adrian's already mentioned, high maternal mortality rates in our Black community, our Indigenous communities, 4 times more likely to die from maternity-related complications than white mothers. That's Black mothers. Also, infant mortality is high, and I'm in Indiana, and we are in the top 10 worst states for maternal mortality. Some of you are up there in the top 10 with me, not proud about that. Okay, let's look at bipolar disorder, and I'm not teaching you about bipolar disorder. I just want to make sure that those who screen positive, some know they were bipolar ahead, some get diagnosed for the first time postpartum, and it's a chronic disorder, high rates of relapse, suicide, and it is one of the risk factors for psychosis. So the DSM does recognize peripartum onset of bipolar disorder. Manic depressive, some people call it, so don't forget that. 60% come in as depressed. They don't come in when they've been manic for a week, and they show up, and if we're not asking enough questions, we put them on an SSRI, and then they go into mania, and then we go, oops, that was probably bipolar. The importance of taking a good history, bipolar 2 or soft bipolar. If you don't looking for it, you're not going to find it. People call it the PPD imposter. Psycheducation.org is a great place to find information on bipolar 1 and 2. Know that it's one of the highest risk factors. There's a high relapse. People want to go off their meds, and they really should stay on meds, and definitely should be followed by a psychiatric care provider all through pregnancy and postpartum. We have a group for bipolar. So and in Spanish, how about that? Psychosis, 1 to 2 in 1,000. I pretended I was delighted in order not to make other people alarmed, but I was steadily getting worse and soon resented having to change and feed Elizabeth. A deep male voice started talking to me, coming to me at times I couldn't predict. He told me I was so bad at being a mom that Elizabeth would be better off if I were dead. The voice told me Elizabeth was sent by the devil. Then I began to fantasize about hurting her. I knew it was time to get help. Do you hear the waxing and waning of psychosis? She was scared by her thought, and yet, if she had listened to the voice, she might have harmed her baby. It waxes and wanes. Andrea Yates, who drowned her 5 children, was first guilty for murder, and George Parnham overturned that in 2006, which was a landmark thing that happened. Not guilty for reason of insanity. In our country, we put them in jail. In Europe, they put them in a mental hospital, knowing that it's a mental health issue. It is a medical emergency. Active suicidal thoughts or postpartum psychosis is a medical emergency. They should be inpatient. 1 to 2 in 1,000. Don't ignore that. Don't call it rare. It happens. 1 to 2 in 1,000 get blood clots in their legs. So, and we look for that. So, number one risk factor is bipolar. Oops, sorry. I just went nuts on hitting the. Okay, we do have groups for bipolar and psychosis. So don't forget psychosis and those pregnancy and postpartum psychosis survivors, those touched by psychosis. So we have videos both in English and Spanish. You can find them on Vimeo, just advertisement, because you need to use those for education. How about the dads? We have dads chat with an expert, lots of dads support group, always looking for facilitators, by the way. If you want to facilitate, we'll train you. Dads, we have found out what? That 1 in 10 dads are 10%. No matter where we've done studies all over the world, we find it's right around that 10%. It looks different. They go to their man cave, they hide, they play video games, they come home later and later from work, they check out. They also feel burdened or trapped. Responsibility, financial responsibility feels like a burden. They're outside the circle of attention. It was all about you when you were pregnant. Then it's all about the baby when the baby's here. And then when the baby's here, now it's all about baby. And the dad or the partner's now thrown way out of the picture. They miss you. They miss sex. They feel isolated. So we have a 2-day training on foundations in paternal mental health. Don't forget your single mothers. Don't assume everybody's coupled, and your single fathers. They are way worse off. No one to help, and they're afraid to ask for help that you're going to take their baby away. And if you look at this, higher rates of postpartum depression, anxiety, and the dads are using risk-taking behaviors and higher rates of suicide. In our queer community, we aren't doing lots of research. We have done research, and what we do find is research shows higher rates of perinatal mood disorders. The queer community has been having babies for years and adopting babies for years, but research has gone on in the queer community, not as much in all of the journals. And we haven't even taken, like, we don't even ask, is this a queer couple? Is this someone, like, we're not keeping. So in the UK, they do keep track of it. They identify that lesbian couples are one of the fastest growing groups, and also pregnant trans men are one of the fastest growing groups. Just remember to ask that non-gestational person how they're feeling, because they're jealous, and they feel left out. So, okay, who gets this and why? Here's your question. People think, oh, it's all about hormones. Remember, hormones cause baby blues. Who gets this? If you have, here's our risk factors, and you should listen to your own risk factors. When I teach in childbirth ed, what I say is, I want you to hear risk factors, and I want you to say, ooh, I have a lot of risk factors. I might get this. Okay, family history, personal history, or symptoms during pregnancy of a perinatal mood disorder. Biggest risk factor, personal or family history of all the things I just talked about: depression, anxiety, bipolar, psychosis, eating disorders, OCD, substance use disorder, all of those things coming in there. Significant mood reaction. You were a moody teenager. You're mean before your periods. You're real irritable. You get irritable and moody with hormonal birth control. History of thyroid imbalance. Other endocrine disorders such as polycystic ovarian syndrome. Decreased fertility, fertility medications, that roller coaster of infertility, diabetes. Are you hearing right now that the person has no choice about their risk factors? We get what we get. They didn't cause it. Inadequate social support, interpersonal violence, financial problems, stress, poverty, Perinatal loss, or recent loss, I mean, any kind of recent loss. Your dad died when you were 4 months pregnant. Your family pet died. You moved across the country. How about that for military families? And then very high stress parenting, military, teen, parents of multiple, single parents, Black and Indigenous family, and the temperament of baby. It's real easy to like a baby that doesn't scream all the time, but if a baby screams, it's real hard to deal with. Complications during your pregnancy, your birth, or with breastfeeding. Oh my gosh, does that complicate things? You're a teenager or you're in your 40s. Seasonal affective disorder, which we're going into in the Midwest. And perfectionism, high expectations. Those people had their life in order and suddenly it's not in order. Pain, lack of sleep, abruptly stopping breastfeeding, childcare stress, relationship stress, losses, childcare stress, relationship deaths, previous losses, miscarriage, neonatal deaths, stillborn, selective reduction, elective abortion, childhood sexual abuse, or any sexual abuse, culture shock. Wow, this is it. I didn't realize my life was going to change this much. Also, relationship with your mom. Your mom's in another country. Your mom has died. You and your mom don't speak. You and your mom argue all the time. And returning to work outside the home after your first baby is a shock because you come home from work and you start your second job, your second shift. And that is a shock. No absolute rest until you've got everybody fed and bathed and in bed, and then you stay up too late watching TikTok. So, always want to look at, is there something else going on here? Should I look at thyroid? Yes. How about anemia? Somebody who had a postpartum hemorrhage, they're not going to be feeling great. They're going to be short of breath. They're going to be depressed. Trauma, side effects of other meds, and also don't miss out on substance use. I've missed that a few times. And then this is just a slide to tell you what I told you earlier. People do not say, I think I have postpartum depression. They say other things that you need to be listening for. This is a great handout from PSI on our website, and it really is a nice synopsis of what all I just said, plus some of the symptoms, plus some of the risk factors, and how we're going to get you better treatment options. This is great to hand out to people, or you can use this for teaching. And know that 6 to 8% of women get gestational hypertension, 6 to 8% get gestational diabetes, 6% get preeclampsia. We watch for that and treat for and test for that in every single pregnant person, but 21% get a perinatal mood disorder, and we're still not asking consistently. So, what is the standard of care? Everybody says we should be screening, right? But then when we anonymously ask them, we find out, but they're really not doing it. About half of them, maybe a third of them. So PSI says, here's our recommendations, even more than these people. Add on to all of these, we should be doing it way more often. We can't just haphazardly do a little screening. We should be asking a lot because we're going to find them. This is a discussion tool that you should hand out to everybody. Anybody that crosses the path of a pregnant or postpartum person should be this is a great, it's not a validated screening tool, but it tells signs and symptoms, risk factors at the bottom. It tells how to get on our free support groups, and it gives our helpline. And this is just a great tool to hand out. This tool comes in English and Spanish for loss and for postpartum psychosis. So that's a great tool for you. You can find all the discussion tools here. Evidence-based tools that are validated is the Edinburgh Postnatal Depression Scale and the PHQ-9. Those are the most commonly used, not teaching on screening today, but we do in other trainings. How are we going to get them better? Now we found them, what are you going to do? They may need a medical evaluation and meds. They may need therapy, and they definitely need social support. Women have said to me, I'm glad I took medication. I'm glad I saw a therapist. But I'll tell you what, if I didn't have my support group, I wouldn't have made it. That's where they can get to before they get into maybe a prescriber. That's where they get to before they can get into a therapist. And new parent classes, I don't know what I'm doing when I'm a new parent, so I need some parenting classes. I need parent infant mental health kind of things. I don't know. I only got taught how to change a diaper on a plastic doll. I didn't really know they were going to poop up to the back of their neck. So our motto from PSI is, you are not alone. Other mothers experience this. Connection and support's going to help you. You're not to blame. You didn't do something wrong. You're not weak. You happen to have a lot of risk factors. Sorry about that. And this is also for the partner. Don't forget, all those things I just talked about could be the partner. The partner could be having intrusive thoughts. They could both be having intrusive thoughts if they're coupled. And with the proper treatment, you will be well. Don't send people to someone who hasn't been trained in perinatal mental health. They will mess them up. Okay. And how do we find them? We find them. I'm going to go through our resources really quickly. And that is to tell you what we have. We do have a certification in perinatal mental health. If you want more information about that, go to our postpartum.net, go to professionals, and go to certification. It will tell you all about it. There's also FAQs on there. And the first Friday of every month, you can come ask questions about certification. I see some of you on here are already certified. I saw you introducing yourself. Here's helpful links. Any questions? Certification at postpartum.net. We have a postpartum planning class. Please send all your pregnant people to our free 2-hour postpartum planning class to get ready. And we're going to talk about perinatal mood disorders in it. We have an app. Get them on the app. PSI has a warm line. We have had it since the beginning of PSI in 1987. It is, you leave a message. It is, messages are checked 8 a.m. to 11 p.m. 7 days a week, and someone calls them back. They reassure them. They say, here's what's going on. Let me get you connected to resources. We tell them about support groups. We tell them about their local coordinators, volunteer coordinators. Also, of course, the National Maternal Mental Health Hotline. That is from HRSA. PSI actually is the contractor, which means that we have trained counselors, certified peer specialists, childbirth professionals answering that 24/7, 365. So same thing, they get hooked up with resources, reassured, and given everything to get better. We have coordinators in every state in over 40 countries, volunteer, who will talk to them, they will get referred to these volunteer coordinators. I did it for 23 years in Indiana. And then we reassure them. We say, hey, here's what we got in Indiana. We've got lots of things here, but let me get you hooked up. To find where your resources are, you go to our website, find this fun map, and hover over where you are, and it'll tell you to fill out a form, and your patients will find it this way too, to find your local volunteer coordinators. We have chapters in every state. What do the chapters do? Oh, that really, I did not mean to do that. The chapters will make money. They earn money in different ways, one of them being the climb. And then we send people to trainings with scholarship money. And so the climb helps that. We're not really climbing, we're just walking around, and we do it in all the states, and it's really fun. And we bring awareness to perinatal mental health and reduce stigma. In my state of Indiana, the Colts actually have Kick the Stigma for their motto in mental health, and they actually give money to our state chapter. So I like to brag about them. How do you find someone who's been trained? You're not going to be on our directory after a 2-hour thing here. But if you take at least a minimum 14-hour foundational training, you sign up on our directory, you'll find people that prescribe, you'll find therapists. Go to your state and look, and you're going to be shocked. There's lots of people trained. You do not have to be certified to be on the directory. Doulas are on there. Support groups are on there. Look at our handouts for all the things we have. Helpline, support groups, chat with an expert, support coordinators, social media. We're on everything. Peer mentor. We have a peer mentor program. Be a peer mentor. If you need a peer mentor or need to send your clients, it's a great program. It's also in Spanish. We have a closed Facebook group for women, also for men, for dads. We have a closed Facebook group for loss, and we also have closed Facebook groups in Spanish. All of our support groups are listed. You will be wowed at all the different support groups we have. Honestly, it's amazing to me. We have over 50 support groups in English and over 28 in Spanish, and they're all free. Chat with an expert is just a phone call for moms and dads. Smart Patients Forum is moderated by PSI, also confidential. So when you say, I don't have anything for our patients, yes, you do. Did you just see all these things you can hook them up with no matter where you are? So we have a medical provider training, and Adrian's going to mention it. She's already mentioned it once. On November 14th, we are doing the medical provider training version for military folks. So anybody can come to it. The Tri-West people, there are Tri-West people that will be invited to come. And so watch for that if you're Tri-West. If you're any other affiliation, you can sign up for it. It will cost $250. But you don't have to be in the military or affiliated. Anybody can come to this training on November 14th as long as you pay $250. The link is not up yet, but watch for the web link. I swear to you, it'll be up by Friday. What day is this? Thursday? No, maybe by tomorrow. Maybe by Monday. Watch for it. We have a psychiatric consult line. Many of you have access lines in your state, but if you don't, call our psychiatric consult line where you can say, I want to talk about a client. And then one of our reproductive psychiatrists who volunteer their time will make an appointment and talk to you about your patient. We have the Alliance for People of Color. Please link up with that group. The Blue Dot Project is heading out to offices and clinics, and we're training all the people, even the people that answer that first phone call in the back office. We are training attorneys. We are heading out. We have brochures. We have posters. So this is just quick through showing you all the pretty pictures of all the things that we have for handouts on our website that you can come and get. The one I showed you earlier also comes in Spanish. Most of our things do. We are on everything social media. Please follow us. We have a podcast called I Am One. We're also social media in Spanish. We have short video clips that you can get on and use for education. We have a bookstore. No book is in the bookstore unless it's been reviewed and we know it's good. We have so many trainings, you'll be wowed. So come look at all of our trainings. Go to the trainings page. 2-day loss training, 2-day dads training, 1-day perinatal substance use disorder training, which will be given for the first time virtually on December 8th. So you should see that up there too. All of you have been dying to go to a PSUD training. We've done it in person. We're doing it in virtual. There is a 101 training where you hear me talk just like this, but for 90 minutes, and I'll do a little more on screening and breastfeeding. There's also a perinatal substance use disorder 101. Everyone can take it. It's 1 hour of just an overview. Come join us in LA in 2026 for our annual conference. You will have a good time. Volunteer with us. Join us if you want to. Information here. One of the benefits of being a member is that we have peer consultation groups for prescribers, for mental health providers, and for doulas. So you are not alone. You're not to blame. And with the proper treatment, you will be well.
Thank you, Bertie. That was an amazing amount of information. And just, are you getting lots of hearts, lots of claps?
I see
Just,
that.
yeah, as a
How nice.
reminder, yeah, we'll be sharing all this information. You'll get the slide deck, you'll get the recording. So all of those different links that Bertie mentioned to Postpartum Support International, all those support groups, everything will be in this, in the presentation that you'll get. And of course, you can just go to PSI, which is postpartum.net, and you can start checking out all of that information. So Bertie, real quick, there was one question in the Q&A that I'm curious. It was, will the maternal mental health training ever be taught virtually, or is it just in person?
You know what? I'm going to be really honest. I keep remembering and forgetting that I'm going to ask Dr. Daniel Singley out of San Diego's, who wrote it along with me and Joanna Cole. And I keep forgetting to ask him if he'll do it virtually. They just did it in Montana, and yes, we do it around the country, but it would be great if it was virtual, but I haven't asked him. So if I ask him and he says yes, then yes. The loss training will not be given virtually. They feel very strongly that it's too sensitive to be given virtually.
Yeah.
But I'm hoping that Danny says yes. So
Yeah.
We'll see.
All right, put that in your to-do list for today.
I know.
Awesome. All right. Thank you so much, Bertie. We
Sure.
are going to pass the mic to Patience Riley, who is also, like Bertie, part of the Postpartum Support International family, and also one of their experienced education trainers. So welcome, Patience. So great to have you.
Thank you all so much. So excited to be here. Love talking about military families and how we can support. Here is a little snapshot of who I am, just in photo form, just to give you a different type of a visual. As Adrian so eloquently put earlier, I am one of our PSI trainers. I'm also a licensed professional counselor. I am certified in perinatal mental health. I'm also the communications manager for the Alliance for People of Color. I've seen some of my peeps that have popped in on here, so thank you all for joining for the support. And I'm also a registered yoga teacher and perinatal yoga teacher as well. I lead support groups with PSI, started out leading our military mom support group, did our mindfulness, and now I do our yoga for postpartum, pregnant and postpartum parents. I have been affiliated with the military for my entire life, you all. My entire life. I started out as a Navy kid. Both of my parents were in the Navy. And as you can see there, you see a handsome young man up there in a flight suit. That is my husband. I am an Air Force spouse. We have two little boys. And I myself come to you not just as somebody who works with military families as a therapist, but I also come to you as someone that has lived experience. So when Bertie went off and talked about risk factors, right? I'm someone that was checking a lot of those boxes. I talked to one of my colleagues, and when she heard my story, she was like, wow, Patience, I was checking the boxes of your risk factors as I heard your story. Like, I, how could you have not had this experience? So sometimes us as providers, hearing and knowing that can be really helpful. And we can try to mitigate some of the risk factors because now you have a little bit of a snapshot. I've seen some PMHCs popping up in the chat. I've seen folks saying, hey, I'm affiliated with the military as well. So I also want to highlight that that is something that can empower and it can help our clients as well, as we are working with them. Due to kind of my background with military families, there is a possibility that as I'm talking about military, as I'm talking about the culture, as I'm talking about different aspects of it, my language may lean a little bit more towards Air Force. And that is because that's my background. So I have some slip ups. But I do want to acknowledge, and we're going to go through different branches because I've already seen some folks talking about where they are, what maybe who they work with, what their own affiliation is. So we are going to get a little bit of a poll of who is in the room. I want to know, how are you affiliated with the military? Does your cousin serve? Do you serve yourself? Are you a spouse? Are you a veteran? We are going to have a poll that comes up here. So I have some folks that are saying, hey, I'm a spouse, I do this. Is there a base that is by you? And because there is one, you say, hey, I'm here so that I can get some additional information. One of the things that I love about having some of my folks in the audience with me is I go over a brief overview for our folks that do not know a lot about the military. And so in this, some of the information you receive, some of the information that you get, it might be review for you, but we can use this as a community learning space because military culture is one in itself, right? And so we're going to dive a little bit into that. And then there's also subcultures. So sometimes I have my Coast Guard people that will give me different terminology that I don't know because that's not the part that I'm affiliated with. So go on ahead and fill out that poll, and then I will check back in once it's all done and completed. So as we're looking at this, I want us to come from the lens of one, hearing what are some of the mottos of our branches. Because when we think about culture, and with military culture specifically, it can go beyond just the person who is serving. It can extend to the family themselves. And so I want us to just think about our different branches and what some of their mottos are, just to kind of set the stage as we go through together. So with our Air Force, we have aim high, fly, fight, win. Army, this, we'll defend. Coast Guard, always ready. Marine Corps, always faithful, excuse me. Navy, not for self, but for country. And Space Force, always above. So hearing some of the mottos and just kind of setting the stage for how things are looking when we think about our military families as it comes to our culture. Y'all, I'm not sure how to pull up the poll myself. So if you don't mind helping me, so I can just see who's in the room and what we are looking at as far as our military affiliation. All right, so we have a lot that are saying, hey, I'm about 41%. I'm not affiliated with the military at all. And so we're really, really happy that you're here. So that's almost half of our attendees that are here that are participating. You may be working with military families. We have some folks from Space Force that are here. Our highest represented is 33% Army. We got some of our Air Force folks. We got some Coast Guard, Marine Corps, Navy being 19%. So we have I see Adrian's hands going up because she's Navy. She has that background as well. So we appreciate all of you being here in the space and are also honoring that there are subsets of our different branches as well. As we go throughout my particular slides, I do have real images of real military families just to bring representation that there's a lot of times we hear about statistics. There's a lot of times that we hear about numbers, but it's really important for me when I talk about military families for you to also see their faces, for you to also see that there is life and there's reasons and behind those numbers that you see. So you will see members of my military family that they've given to me and have allowed me to share publicly when I train on working with military families. So I like to bring note to that as well. So when we think about military culture, and we think about culture, we think about background in general, the military has one of itself. Sometimes we think about our own cultural backgrounds, our heritage, how it relates to like race and ethnicity, but the military culture, we have one of our own. And first, it's the things that we can see. A lot of times folks will see the uniform, they'll see the haircuts, they'll see the hair pulled back into the bun. We'll look at the different patches that people wear that are on their uniform. Maybe we can see whether or not they're enlisted, so have maybe more of that specialty skill and they're actually doing the work. Or maybe we're able to see that they're an officer, that they're doing more of the administrative, they're overseeing, they're taking care of missions. Maybe that's part of what we're looking at. We might see a little bit about their job position and their titles. We might see what squadron that they're a part of. We also might hear language, the type of terminology that is said to one another. And we're going to go a little bit into that. And I like to think about language, and sometimes we have to learn how to talk the talk to engage with our military members. Me as a therapist, that's one of the things that I do a lot. I listen, I see, and then I also engage in that conversation. What about our internal characteristics? One of the reasons why I wanted to share some of the mottos is because this can play a big role on different values and beliefs that someone has about themselves, their role, and also how it looks within their family. And so when we were hearing certain things, my mother, for example, when she got pregnant and she was told, hey, you have to stop breastfeeding because we need for you to deploy, they let her know you weren't issued a family in your CBAC. She was in the Navy. They didn't issue a family in your CBAC. And so when I was going and I'm looking at the different models, not for self, but for country. So we're also thinking about the institutions as a whole and how those models can extend not only from the person who served, but extend into their families. Maybe there's certain traditions that take place. Even when we think about where the flag is, that's kind of a simple tradition, depending on what has happened with certain events. Hearing the song at the end of the day playing and stopping and not walking. Those who are not affiliated with the military may not realize that that is something that you do. Also, worldview, and I have to bring up stigma, especially stigma around mental health, receiving help, asking for help. Because when we think back to our mottos, being mission ready, having to be there to support. I worked as a military family life counselor and I was embedded within our maintenance as well as our security force squadrons and one of our flying squadrons. So working with folks who had to make sure that planes were getting off of the ground, they were on the planes as well, and then also security forces as military police. And one of the things that I was able to do within our squadrons was try to break that stigma by being present, by talking about emotions and wellness and things in a different way so that we could still get our military members support, help, care that they need, because there is that huge stigma around that. And also the stigma of what if I am not doing so well? Luckily, with one of my other colleagues that was in a different helping profession in mental health, and also another one of our nurses from our family support, we were able to put together a group for those that experienced early pregnancy loss, right? We ended up hearing from one person that there was a need, and we were trying to break that stigma related to mental health services and asking and receiving help. So Adrian went over some of our numbers, some of our statistics. And if you do not have MMHLA's fact sheet, download it. It is extremely helpful. You do not have to memorize all the numbers. They did it for us, y'all. They did all of that for us. Download it, look at it. But just wanting to highlight in some of these, 16,000 active duty service members give birth, 85,000 military spouses give birth. That's a lot of babies. That's a lot of giving birth. That's a lot of people touched and a lot of people affected within this culture in itself. So even if you aren't affiliated with the military, that's why we're so excited for the folks that are here. You may touch a military family, and what are some ways that we can help them? About 35% will experience a perinatal mental health condition. Birdie did a beautiful job of giving you a snapshot that it's not just postpartum depression, it's not just crying, it can be other things. Also, our women service members with a personal history of deployment experience perinatal mental health conditions at twice the rate of those that are not deployed. That's going to show up on like our risk factor list specific to those that are in the military. And also, why I want to highlight so much about values, about traditions, about military culture is this big point right here. The research study that shows that some spouses worry that their mental health challenges could harm their service members' military career. I'm not the person that's in the military, but this is maybe keeping me quiet as the family member. So there is that stigma that can spread just beyond the service member, and it can also spread into the family. So commonizing these conversations about mental health, about emotions, about wellness, and looking at some of our language. Hey, let me just talk to you about something that affects 1 in 5 women. And going over those fact sheets that Bertie was talking about is so, so helpful because there are some risk factors affiliated with our military families that are on top of all of the risk factors that Bertie just went over. There's so many of us that will probably raise our hands when you hear like the term, the military lifestyle is a unique lifestyle. And I think that that's just a very pretty way of saying that we have all of these additional risk factors. So this is kind of us like being real with each other about what some of those look like. So we have those frequent moves that are taking place where we're going and being stationed from, you see, I'm using some military terms here, but I know I'm amongst friends. But where we're going and moving constantly. With that comes me being pulled away from my immediate support system. I'm being pulled away from my family. I'm being pulled away from my friends. I'm being pulled away from all of the other little things that help me operate through life. My dentist, my doctor, who does my hair, who gets my eyebrows together. Like those are big and important things that I have to find. I'm pulled away from my community, my gym. So that support piece with that frequent moves, those can go hand in hand. And what happens if I established a support in my new spot, and as soon as I feel like I'm getting my footing, I get pulled away from that because we move again. So it's also that starting and stopping that happens over and over and over and over again for our military families, right? Also, long work hours. Having one person that is at work for a longer period of time. What if there's a dual household? What if the certain type of work conditions are dangerous, life-threatening? We're talking about combat exposure, previous mental health diagnosis. So also looking at sexual trauma, PTSD as it relates to our service members. We're thinking of times of separation. And when I say times of separation, I'm thinking about whether it's a deployment, which is a longer period, or even if it's something that is shorter. What about our military families that are overseas? I see that we have people that are around the world joining us today. I've had folks join my support group that are part of the military and affiliated, and they had a hard time getting access to care, maybe because they themselves were a therapist and I live overseas. So coming to a support group that's available was life changing for them. There's times of solo parenting. With high stress parenting, we saw that single parents, that is a risk factor. So I want us to also know that just because our military members or military families might be partnered, there may be times where they fall into that what would seem like a single parenting because they're doing what I like to say is solo parenting. They're still doing it on their own while we're also keeping in mind that they may not be by their family members as well. They may be by themselves. So that brings in that unique aspect that we talk about with our military families and this huge lack of physical support. So let's pull in that reframe. If you train with me or if you attend any webinar that I do, I always like to have a reframe. What are some of our protective factors? What are some of the things that protect us with being a part of military families? Well, we sure are some adaptable people. We're flexible too. We are very resourceful. We know how to find our way around. How can I get to the solution of this, the solution of that, right? We also do have some access to healthcare. And that is really helpful. And that is one of the things that does protect our military families. When we do educate people about perinatal mental health in a primary care setting, we know that there can be improvements. So those screenings that Bertie was talking about, that little bit of education, that can be extremely helpful. So for my folks that were putting in the chat, I work here, I work there, I work all that with military families, that psychoeducation, that can be a huge change in just weaving that into the work that you're doing, just saying, hey, just how I'm talking to you about how to nurse, breastfeed, burp the baby, change the diaper. Let me talk to you about this as well. Also, grit. I started using grit. Like I said, I was an MFLAG. I started using grit instead of resiliency because every time we said resiliency, everybody rolled their eyes. It is a little bit overused as a term, so I acknowledge that. But we do have the ability to overcome because of how our lifestyle is. I like to say we put our little shield and our armor on as military families. However, with resiliency, I also want us to first validate. We want to validate somebody's experience. If someone is coming in and they're saying, hey, I don't want to move, this sucks, we can validate that experience for them first. And then we can also look at how they've been able to overcome that and how they have put that armor on and they have that grit, right? So we can do both things at the same time. So with our risk factors, we're listening out for them. We're doing like my colleague said, I was listening to your story and I was kind of checking the boxes to see if there's any way that we can assist and we can mitigate because we know when we are not feeling well, sometimes it's hard for us ourselves to access that. It's hard for us to reach that information and that knowledge. So this is a little snapshot of different ways that we ourselves, we can support military families. One, knowing a little bit about military culture and just identifying that it is a culture in itself. And then there's also subcultures. So think about where you're located. Are you close to an Army base? Do you work with reservists? Are you a part of the VA? Do you know somebody that is there? Are you close to an Air Force base? What is your area? And learning a little bit more about that subculture. We're going to get into a little bit of language, and I'm going to have my folks help me out who are affiliated, helping with a perinatal support and care plan, pulling that into the fold. Also, Bertie had some educational things, but the deployment cycle, maybe educating your families on what that looks like. We're going to hear from our TRICARE folks about insurance as well. Military specific resources. I have a lot of those hyperlinked for you and listed out. Also, what is the power of community specific resources? Because remember, I've been pulled away from everything that I know when I move to a new area. So, my folks that are from the local area, you are also the secret sauce for our military families. You can get me connected to community support because there is a research study, and I think Mara may have already shared it, where it highlights that spouses shared that one of their highest protective factors was support, was receiving support. And that helped with their depressive symptoms that they were experiencing. So that's why we highlight so much social support. It is so, so important. And it can really, really change the trajectory of someone's story. I'm raising my hand on that one. So we're also promoting some type of community care there. So let's learn how to talk the talk. Let's help our friends out. Let's help out our 41% that is here with us that said, hey, I don't have any affiliation. And you may have learned this from talking to a military family. So me as a therapist, somebody may have come into my office and they say, hey, me and my family just PCS care. I'm currently living in TLF and I'm tired of going back and forth with TMO on my household goods. I'm about to go check out the CDC. I was put on the wait list. It was about a year and a half that I was sitting there. I got a baby that's on the wait list. My toddler still hasn't gotten a space in the room. And then after I'm done meeting with you, I'm heading over to EFMP to talk to them about possibly getting off from my daughter getting off because everything with her tongue tie has been taken care of. Now, my husband, we don't really know how things are going to be looking, but I'm going to get some additional information from the readiness for sergeant. How many people may have gotten lost in that conversation, right? I'm seeing Mia and Adrienne raising their hands. Who may have gotten lost? So my military folks, like it's almost like a different language, right? When we're talking to military people. I'll call my girlfriend Charity all the time and we'll just be going to town. She's a military spouse. She's also a perinatal therapist. And we will be throwing out all the acronyms. Our other girlfriends have no idea what we're talking about. No idea. But someone has come into my office and had a conversation with me like that. Now I was able to follow that conversation and she was very agitated. She was very irritable, rightly so, because her stress levels were high. She just moved. Now, if I'm having a hard time following that conversation, that could slightly be a barrier, right? Not the end of the world. So I also don't want you to feel doubtful on yourself, but I want to give you a little bit of a cheat sheet. And this is your cheat sheet. And some folks may have some additional things. So my military people, just drop a couple of things in the chat that explains what are these? What do these acronyms stand for? Just because I won't have the time to go over it. So as we're still going, your friends that are here joining us can look and see. So let people know what is meal to meal, what is PCS, what is TDY, what is TMO. Y'all been lighting the chat up. So go on ahead and keep doing it now. Don't get quiet on me, people. Don't get quiet. All right. So we have for PCS, Permanent Change in Duty Station, CDC, Child Development Center, EFMP, Exceptional Family Members Program, Transportation Movement Officer, TLF, Temporary Living Facility as well. Temporary duty for TDY, that's our shorter time, right? That we're having there. Exchange, BX, NEX, PX. I like to say that's like our Ross or our TJ Maxx. And then our commissary is our grocery store. Meal to meal is like military member married to military member. There's also meal to civilian. So different ways that we can arm ourselves. So yeah, so Nicole, ACS, Army Community Services. Like I said, I am very Air Force leaning with my language, so I apologize for that in advance. So we have some of these terms that we can arm ourselves as we are talking with our military families so that we can follow a conversation with them. Because what I do as a therapist, I have big ears, I have big eyes, and I have a very, very little mouth. So I'm spending a lot of my time listening. And so I want to make sure that I can follow a conversation. So I like to arm my folks that aren't affiliated with the military with some of the terms of what our acronyms mean. Because we don't mean to use all of these acronyms, it just kind of happens. It just flows out of our mouth and we just go to town, right? So thank you all so much for helping with that. And it's also helpful for you if you just cannot follow the conversation. It's okay to ask. It is okay to ask the question. Something else that we can do to help our military members is creating a perinatal support and care plan. So I have a plan that I create with my clients. I call it their postpartum mental health care plan. There are free ones that are online that you can download, that you can get access to. You can customize your own to fit whatever profession or way that you are working with your clients. Maybe you're doing a childbirth education group. And so you're talking about that. These are some things that I have listed on mine. I like to list different providers and resources. This is military as well as civilian that they're working with. Who's providing your medical care? I list myself as their therapist, right? I'm adding doula. When I was in Nebraska, there was an organization called Milkworks that had lactation support groups, also assisted with general lactation support. I added that. I added the WIC office that we had on base, the one that was also in the community for my folks that I was seeing as well. Where do you want to do free childbirth education classes? Is that something that's available on base? Are you having to go off base to deliver? What does that look like for you? So adding those different resources. This is the time you can provide psychoeducation on perinatal mental health and use one of our fact sheets. Also, how are you doing your self-preservation as a new parent? We can practice this during pregnancy, giving them psychoeducation on sleep hygiene as it fits to them. So listen to them and what things might be beneficial. Let's talk about nutrition. What are the snacks and things that you're going to have close to you in your areas around your house so that you can feed yourself? Are you going to create meals and freeze them? Are you going to set up a meal train with the squadron? We love mealtrain.com around here. Also, how are you going to get some movement in? Just because we know movement also helps. What are some of the supports that are available and that are around you yourself? Because, like we said, research shows us that when there is support, that is a protective factor, especially for our military families. So, what does that look like for them? Is there one person? Can we get them set up? For the Air Force, we say key spouse with the key spouse program. Do they even know who their key spouse is, and do they have their information? And what does that support look like for their squadron? How can I ask for help? We talked about stigma as well. Maybe I don't want to ask for help, but if they're coming to you, that's giving you their opening, and maybe you can coach them through. How do I ask for help, and who do I ask? And what are the particular things that I'm asking them for? So don't ask the person that you know is going to want to come over and hold the baby if they can put in a load of laundry for you. That's not their job. We also have to make sure that we're realistic in the ask that we have for people. Don't ask your friend who doesn't really care for children if they're the one that can watch your toddler while you do something. They're probably not that person that's going to do it, but they may bring you over a hot meal and leave you alone. Also, tending to your own needs and your self-care. What are some of those low maintenance things that can be done during this time? And this might be just trying to get rest or moving our body, or some of the things as it relates to sleep hygiene. And also focusing on parental leave. Are they themselves going to be going on parental leave? What's the parental leave of the military member? So bringing highlight to this, just because there has been some advancements, there have been changes even from when I had my first son to when I had my second son with the military leave program. So just want to bring this to you all's awareness as well, just because it's something that you may want to share with your clients or go over with them. I will have this linked in a future slide, just the general snapshot of the military leave program. Really important things. There's convalescent leave as well as parental leave for birthing and non-birthing parents. So there is a difference in what this looks like. Please, please, please review the regulations for whatever branch that you are a part of or whatever branch that you work with as well. Also noting that with the leave programs, some of them also cover loss. Loss. So this is loss of pregnancy, also loss of a child. I dived in deeper with the military leave program. In 1 week, I had 2 separate clients that experienced a stillbirth. It was an unfortunate reason why I had to look into it. But as you can imagine, that was not something that my clients were able to do. I had one that was serving active duty, and I had another that was a spouse. And so I had one that was a mill-to-mill situation, and they were both Air Force affiliated. And this was the time where I asked my husband, I was like, hey, are there is are there anything around leave and taking time off? Because when one of my clients, she just said, hey, I don't even have any idea of what I'm going to do with getting back to work. Like her mind immediately went back to work, right? She thought about that. And that in itself was something that had to be unpacked. I'm sure you all are thinking. So he ended up pulling up the regulations for me, and I dived a little bit deeper. And then that's when I was able to see the leave regulations around loss and how the military is giving and issuing and providing our service members with leave around loss as well. So just noting that when someone is in a postpartum period, it doesn't always equal a live birth. So that's associated with that. So just keeping that in mind. Our friends with MMHLA has this nice little graph for us. I like to always put this up here for people just to note that there are different programs that are available and out there to support our military families. So for you to look into that as well, we will be hearing from TRICARE, our new parent support program. I think I've seen a few folks in here that are working with those types of programs. Wonderful, wonderful program. So when we look at deployed versus non-deployed, what are some of the research? What is it telling us? Well, you heard me share about my client with the loss, and I thought about her when I pulled this up. Sometimes our service women are planning their pregnancies around specific times they don't want to give the perception that I'm not trying to pull my weight. I'm not trying to do my work. I'm not trying to avoid being deployed, right? So that's what I also thought about with her when she was like, oh my gosh, what am I going to tell everybody about work? When am I going to get back to work? Because now with her pregnancy did not come a live birth. Also, some of the research is telling us that there is a link between spousal deployment and preterm delivery and postpartum depression. So it can go up with the deployment. And then also a link around time frame, an increase in depressive symptoms based off of when someone is deployed, the service member is. So the highest being when the service member misses the labor or birth of a child. Second highest being when the active duty service member is away from the spouse during postpartum. And then next in line is during pregnancy. So us also keeping in mind when we're working with our families, do they fall in any of these categories, right? We're trying to identify risks so that we can help mitigate risk. So something that we can use when we're working with our families, or maybe we just use this as a psychoeducational tool. You can print off something about the deployment cycle from Military One Source, and we have that linked for you as well about the deployment cycle. There's pre-deployment. So this is the part before the person goes. Maybe that distancing from their partner that anticipation of it. Maybe you're working with them with their mental and emotional wellness during that time. The deployment comes, it hits that overwhelm of how the lifestyle has changed into that solo parenting or being by themselves. Then starting to get the groove. I like to say the midway section. That's why it's there in the center. You're starting to get your independence. You have more confidence. You're doing things the way that works for you. And then, similar to pre-deployment, pre-integration, they're about to come back into the fold. Maybe I'm nervous. How is our relationship going to be? Are we going to connect? I'm so used to doing the things the way that I'm doing it now. How is it going to be when my partner comes back? And then also our reintegration. There is a honeymoon period that happens. Some of my friends joke about deployment babies that end up being pulled into the fold. So there is a honeymoon period, y'all. We have to acknowledge that. And then also negotiating, like, how are we going to do things and shift our life, especially if maybe when my partner left, we had a 2-month-old, and now that baby is now 11 months old. That's a difference. And keeping in mind also our service member that's gone in the phases that they are experiencing, right? Because maybe you are working with the deployed service member. So how can we manage our times of separation? Right there, my son right there, he has a daddy doll. That is my husband on there, and both of my boys have a daddy doll. So when my husband is gone, they have him. They have him on the couch. He's going and exploring different things. He's laying in the bed with them. He's doing all these things with them, and dad is there. We have the nice thing, like we have phones. Back in the day, my dad only could write us letters. He was on a ship. Like we could never talk to him. But are you going to FaceTime? How are you going to connect at a distance? Is there a way that you're going to do some time tracking, especially with your little ones? Are they going to eat a Skittle each day that mom or dad isn't present when they're gone? What is that community care going to look like? Or are we going to outsource any services? Is there a family care plan? Do you have to have things put in place? Did you have to go to legal? So looking at different ways of how they can manage that separation. So connecting them to resources. I have a list here of a bunch. You all may have some others, some that are military specific, and then some that can be community specific as well. Because remember, y'all, you are also the secret sauce to getting our militaries connected to the things that are in their area that they may not know about. They may not know about particular Mom's Morning Out programs or Parents Morning Out, drop-ins, community play centers. They might need to get connected to the perinatal providers that are there for them, educational services, and then also things that are available on base. Noting that all of our military members may not be familiar with all of the military services that are available to them. I learned a lot more about what was available on my base after I started working as an MFLAC. So that is something that I like to point out as well. Here is a list, and a lot of these things are hyperlinked for you all, of some military resources. PSI, we got a group for that. We love to say that. We got a group for that. We have a Military's Moms online support group. You do not just have to be a spouse to come. As long as you are affiliated with the military in some type of way, we would love for you to join us, and we would love to see you there. You don't have to be in the States. You can be a CONUS as well. You like how I ended with an acronym. But please download our app, even if you are not a parent, even if you're a provider. It can be really difficult for our families to get connected to support. So if you have to pull up the app and help them sign up for the support group yourself as a provider, please do it, because that is a huge protective factor for our military families. So thank you all. I am going to pass it on.
Oh, thank you so much, Patience. That was so terrific. And you're right, the military is its own unique culture. It really is. It has its own language, all of those things. So really terrific. There was a question that came in that I'm not sure if we actually have information for, but somebody noted
Great.
that Secretary Pete Hegseth has made several announced last week the flag rank officers that were going to be some changes in the military. And just wondering, the question was, have you seen any of that trickle down yet? But I'm guessing because this was just last week, that people are still trying to figure out what all of that was.
Yeah, my husband has been coming home and sharing a few things with me, but I'm hesitant to speak on any changes from just last week.
Yeah, that's what I figured. Yeah, sometimes
Yep.
these take a while to trickle down.
Yeah.
All right. Thank you so much, Patience. All right, we're going to switch gears here and come down to some brass tacks about what TRICARE is and how, if you are a mental health provider, how you can become part of the TRICARE network. So TRICARE is the health insurance system that provides comprehensive medical coverage to active duty military service members, to retirees, and to eligible family members. So it's a huge health insurance system, basically. And it is divided into two sections, the East and the West. Okay. The contract was reestablished on January 1st of this year of 2025, and we saw some movement of a few states from the East to the West. So there is one company that handles the East, and that is Humana Military, and one that handles the West, and that is Tri-West. So we are now going to hear from our friends from each one of these specific programs who will talk about how to get paneled. So first up is Jackie Bush, who is with Tri-West Healthcare Alliance, and they handle the West part of the TRICARE system. So passing that over to you, Jackie.
Well, hello, everyone. My name is Jackie. I am the manager of the Provider Network Development Team with our special programs at TriWest. These programs include our Autism Care Demonstration Program, our Childbirth and Breastfeeding Support Demonstration Program. I've seen some doulas that have been in the audience, so I was glad to see that. I've worked with both TRICARE providers and VA providers for several years, and I just wanted to jump in today and share a little bit about TriWest. At TriWest, we started in 1996, and our goal and our sole purpose at that time is what we continue with today. We want to serve our nation's military and our veterans communities. It's who we are, it's what we do. We partner with the Department of Defense and the Department of Veterans Affairs to create a network of providers throughout the communities. Currently, we have over 4 million beneficiaries under our umbrella. And I'll let that sink in because for the providers, that's a lot of patients to take care of, and we value that. If you were to draw a line, I know Adrian had shared a little bit about the changes of the TriWest program. But if you were to draw a line of what's in my market and what's not in my market, the TriWest market encompasses everything from California over to Illinois, down to Wisconsin, Illinois. We're going to slide on down to Arkansas and Louisiana. That is all under the TriWest. My co-worker, Chris, he's with TRICARE East, not TriWest, I'm sorry about that. And his company works with, Humana Military works with those providers in the East area. Let me find my mouse here. One of the things, to share with you is that all providers within the TRICARE program, regardless if you choose to be in network or out of network, you must be TRICARE certified. Okay, and there are ways to become TRICARE certified, and I'm going to share with you a couple of things. Really brief here. The best way to do it is determine which region you're in. Are you in the East or are you in the West? And there are those providers who kind of sit in the middle, and sometimes you may need to be in both, depending on which, if you cover both sides of the state. So identify your region. Then you would go to that region's website and determine and find the provider certification application. Complete that, submit it, and then you're going to be reached out by either company to begin the next steps. So the certification applications, they are going to require additional documentation, more than just an application. It's about a 3-page document, but they're going to also ask for your basic life support, your CPR, specific licenses, some certification applications are going to ask for your criminal history background check, depending on what your specialty is. And I'm talking from my autism provider, so that's always a requirement there too. So once you get your certification, you're going to receive a letter. And if you don't receive a letter, you're going to get a phone call. They're going to call you and say, hey, we've got you certified, and now let's begin our journeys together. Would you complete this link so that we can send you a contract so that you can start taking care of these 4 million plus patients that are in our markets? We value the, the, the programs that we service, I'm sorry, more than, and we value our providers. To get connected with TriWest, of course, you can go to the triwest.com provider website. It's all right there. With the age of technology, we make everything easy. We give you a link, you go click here, there, and next thing you know, bam, we're sending you emails and we're talking together. So it's very, very simple. I appreciate everyone being here. Again, thank you for your time. I've learned a lot today from Patience and Birdie, and I've enjoyed myself. Thank you.
Thank you so much, Jackie. We appreciate you being here and for making it sound so easy about how to get paneled, right? So then we're going to turn the microphone over to Chris Taylor, who will talk about what the process is for the TRICARE East region.
Thank you. Good afternoon or morning to everyone based on your geographic locality. My name is Chris Taylor. I have been working with the TRICARE program and specifically with TRICARE provider data going on 23 years. So a lot of that time has been spent with TRICARE certification itself. And so as Jackie mentioned, not going to kind of belabor some of these, it is the same underlying policy requirements that both TriWest as the West Region Administrator and Humana Military as the East Region were following the same playbook from the Defense Health Agency, who administers the TRICARE program, and then we administer that. So we're working from the same manuals. Some processes might differ. So what I have here on this slide is that step one, similar to Jackie's process with TriWest. Here is the specific link to Humana Military's certification applications. In the past 2 or 3 years, we have moved away from paper applications being faxed and mailed in to online certification applications. So this link will take you to the main landing page, and then there are additional links based on your provider type. Labor doulas fill out theirs, mental health counselors find yours there. About 98% of these are digital. Nothing ever gets done 100%. So we have a couple stragglers that link will take you to the paper form that will still have to be faxed in. The vast majority are online now, which has streamlined the process. It is a fast fail. You can't submit it without giving the exact information that's required. Again, if that basic life support or CPR training certificate is required, that has to be submitted in order to proceed and actually submit that application. So we've streamlined the process to speed it up, make it easier for our providers to become TRICARE certified. In addition to some, fun technologies, something we have is a certification application tracker. I consider it like Domino's pizza tracker. Where is my application in the process? It's in the oven. Is it being baked? Final touches going on there. So you can track that so that at the end of the day, yep, it is done. You might receive that email that, yep, certification is complete. We'll also communicate if, yep, what was submitted wasn't exactly what we were looking for. Our representatives will reach out, guide you through that process to completing TRICARE certification. And then, so again, kind of as Jackie mentioned, any provider, you do not have to join the network to treat TRICARE patients. Certification is required for all of our providers. So once you have been certified, here is the link to start the journey to join the TRICARE network. This depends on where you are located, what kind of coverage we have. So there's not all providers. We might not be accepting those applications to join the network at this time, but this is where you would start that journey, learn more. We want to make sure we have a good coverage for our beneficiaries. Final thing I want to talk through, all these terms, just like the military terms that patients went through, there are two different processes. There is certification and then there is credentialing. And so I always like to talk about these. I've explained this even internally to my company many times. They sound similar, but they are separate processes. So all providers are required to go through that first TRICARE certification process in order to treat the beneficiaries. And only providers who join the network have to go through a separate credentialing process before that full network application is complete. So again, what's one more hoop to jump through? That's just kind of part of life at this time. But again, that's the main thing I wanted to talk about. Those are two separate processes. All providers to treat military members have to be certified. Only those who join the network need to be credentialed. And final thing I'll say is, again, the undergoing certification, ultimately the goal is make sure you meet all of TRICARE's requirements. The ultimate goal, get your data correct on the system so that when the claim process starts, all of those elements are on file correct. You pass that barrier and avoid any types of claim disruption or denials and all of that information. So it is step one, become certified. That's just the first place to start to get the journey rolling.
Great, thank you.
Oh, one final thought.
Yep.
I clicked on it too fast. I did notice again that there were some providers who were outside of both the East and the West region. There's actually an overseas TRICARE contractor, International SOS. I'll make sure to include information about their specific place to start in the materials that'll be sent out.
Oh, thank you so much, Chris. Really appreciate that. That was an oversight on our part. Thank you. So there's a couple of questions that have come in that Jackie and Chris, I want to tee up for you. First, somebody asked, if you only do virtual therapy, do you have to have an updated first aid certification? Yes. Still not, Jackie's nodding yes. Okay. And then a question says, are there numbers that can be provided for authorization concerns for TriWest? And this goes on to say the new guidance to provide services without an authorization is really complicating our ability as providers to get paid for services. So Jackie or Chris, Jackie, that would be for you.
Well, the first thing I'm going to ask is, are you hooked into Availity? Can you go in and work through Availity for your authorization processes? And if so, or if not, if you still want to speak with someone, of course, you can call the 800 number, which is 888 and our name TriWest. And there will be prompts that will direct you to the authorization team, and they have customer service specialists that can assist you there.
Awesome. Thank you. So use Valent. They continue to refer us to the PCP. Yeah, so Rosina, I guess I would call that one, or Jackie, do you want to? There it is. Jackie put the number in 188 TriWest. I'm sorry that you're having those. Oh, I'm sorry you're having difficulties with that, Rosina. Maybe we can connect you with Jackie after this or somebody at TriWest. Thank you. Okay, so we know we've covered a lot of information today. We want to let you know that there are other places that you can learn more about either maternal mental health or the military. And again, there is this fabulous one-day symposium that's coming up on November 14th. Bertie said that the registration will be open hopefully by Monday at the latest, so we'll share that information when we have that. And that's focused initially on TriWest, but then others can pay to participate. We also have listings of other maternal mental health training. So Postpartum Support International, which is the world's leading organization in providing trainings about maternal mental health and related topics, has a whole host of trainings. You heard Bertie mention a few of them. There's short trainings, there's full day trainings, there's in-person, there's virtual, there's a certification. So please check out their webpage for the trainings that PSI specifically offers. And we at Maternal Mental Health Leadership Alliance also have put together a database of trainings in perinatal mental health. It's an online database that you can search on different topics, whether it's free, is it virtual, does it have CEUs, and it will link back to organizations like Postpartum Support International that are offering these trainings. So it's an opportunity to see what other trainings are available in this whole sphere of maternal mental health. And then if you want to learn more about the military culture, Again, there's a variety of different trainings. These are 3 that I recently tested out. Psych Armor offers a very, very basic 40-minute free course that's pre-recorded. And then the Center for Deployment Psychology offers a much longer online course. And then you can even do one through STAR Behavioral Health Providers to get continuing education units. So for example, if you are an expert in maternal mental health and really want to learn more about the military, you could do like one of these longer versions and really get an in-depth training about the military culture, because as Patience so rightly said, it is a culture unto its own, and super important that if you're working with folks in the military, that you have this knowledge so that you're speaking the same language. Okay, so we're going to do a quick poll, and then we're going to move into our Q&A. So quick poll is just one question. Did you find this webinar helpful? This gives us immediate feedback that we can share with just to know if we're doing a good job, and to share with our funders. And of course, we'll be sending out an email with a longer survey that asks specific questions about how we can improve these webinars and what other topics you might want to see included. Okay. So again, I want to give a big round of applause to our amazing speakers today. Patience, Bertie, Chris, and Jackie, we are so grateful for you. Grateful for the time that you put in preparing for this, and also for the time being with us today. And we know that there'll be follow-up questions as well. And so we just want to let you know how much we appreciate your time, your talent, and all that you do to help our military families. And we, again, will be sending out information with after this with additional information, including contact information for all of our different organizations. Please stay in touch, follow us on social media, all of those things. Maternal Mental Health Leadership Alliance and Postpartum Support International and the Alliance for People of Color. This is what we do all the time, 100%, is maternal mental health. And if you have a question, you want to get connected with somebody, we are the ones who can make all of that happen. So you've got the right people in the room. And thank all of you for taking time to be with us today. Again, after this webinar, we will email you with the brief survey, the presentation slides, the webinar recording, and some of the additional information that we've been discussing. And so now we'd like to hear from you. We've been trying to answer the questions in the chat as we've been going, as well as in the Q&A. But if there's something that is still seeing all these great, thank you so much, great training. Oh, we love when we hear that. We also want to know how we can do better, so please share that with us as well. Curious if there are questions in the Q&A that we have not been able to answer yet. Oh, here's one. For TriWest, any insight into the challenges with delayed reimbursements, and will this challenge resolve soon? Ooh, sorry.
Oh, well, yes. I would refer you to the TRICARE.mil shutdown. There have been a possibility for a few slight delays. We do anticipate that to be changing and payments to be released very soon.
Oh, I'm sorry to hear that. Right. Somebody just dropped in the chat. It's been a nightmare for family. This is really, what we're going through right now with the government shutdown. And it's just, it's so tough. So many people don't know what's going on, how long is it going to last, what the impact is for different people. So we feel for all of you, whether you're a government employee, a military family, anybody who's being impacted by this. Right. Any other specific questions? I'm looking in the chat. There was a question I saw earlier in the chat. Bertie, maybe you could answer. It was about the National Maternal Mental Health Hotline, and do folks on the hotline or like PSI's coordinators receive specialized military training? Oh, you're still muted. Yeah.
I say that so often to other people. You're muted, and I did it. I said Patience is going to help me with that, but I will tell you that off the top of my head, I don't know the answer to that.
Okay.
But they're all trained in perinatal mental health, in emergency, whatever. And I do know that we do a handoff to the suicide hotline if it is a suicide call. We do a handoff to domestic violence hotline if it's domestic violence. But you know what? I don't know. Do we train the hotline people with military. They've all taken our trainings, and we have a section on military that Patients, of course, has helped update. So I know they've gotten that, but that's something to think about. Maybe Patients, we should do more of a, like, you know what
Just
will
like what you did.
happen?
Yeah.
If this is available for anyone to watch after this, we will recommend for our hotline counselors to watch this 2-hour military training and invite them to the um, November 14th all day. So I'm glad that's a good question because
Yeah.
it's
That's
something that they all should know a little more about. We all should know. I learned so much today
Yeah.
about even the military aspect. So thank
Yeah.
you.
Yeah, that's a great idea. You know, one thing that I learned, I was in the military. I am familiar with some of the stigma around mental health in the military. But the fact that, you know, as a spouse, like if you're married, if you're not the military person, but the spouse, you're worried that your mental health condition could impact your spouse's career. I don't think there is any other industry in the world where that is an issue. And there's just still so much stigma around mental health in the military. There's so much more acknowledgement and awareness about post-traumatic stress disorder and traumatic brain injury. But in terms of maternal mental health, anxiety, and depression, it's still, you know, it's very much a taboo and stigmatized issue. I wish it were not so.
Oh, no.
Yeah. You know,
Yeah,
and one of the
I'm glad you brought that up because that's really a big issue. And I've heard even people in my own family, friends who have sons and daughters in the military, and I've actually heard them say things, like we're strong and we don't get depressed, and that's just not an option. And then also talk about just the worry with deployment, but also that I'm afraid to go to a therapist in the military, afraid to go get on medications. Will that affect my career? Will it affect my spouse's career?
yes.
So that really, I'm glad you brought that up because that's really something I hear a lot of.
Right, right. And I know the military is working hard to dispel some of those rumors, but Patience, maybe you can talk about that a little bit more.
Oh, and I also wanted to go back to another point as well when we were talking about specific training around military and like our hotline folks and our support coordinators as well. One of our support coordinator staff is here, Melissa Bentley, and she did drop in there for us that there is a plan going forward to train all of our support coordinators at PSI on military related culture issues, families.
Yay.
And I did not include this in my slides for military specific resources. In addition to our support group, we do have support coordinators within PSI that are affiliated with the branches
Yep.
as well as reserves,
Yep.
and in addition, veterans. So with getting connected with PSI through the helpline, folks can also get connected to the specific support coordinators with the groups as well.
Yeah.
Well, you
Yeah.
can add that for November 14th. You got another slide, Dad, now.
Exactly.
Yeah.
So thank you, Melissa, for kind of pointing that out and bringing that to our awareness too.
And we know how important it is when somebody is reaching out for help that they end up getting connected with somebody who looks and talks like them, right? Whether it's a person of color or a person who's wearing the same military uniform, because then you have that immediate connection of like, you know what I'm going through. You're walking in my shoes.
Right.
And so it's so terrific that PSI has these military coordinators who can speak that language, right? Great. And Melissa's dropping things in the chat. If you want to join as a coordinator, please email her. That's awesome.
Could use help with the Navy, she said.
I could be your Navy military coordinator, but I'm
There you
guessing
go.
that I probably don't know anything about the current active duty situation, but I can help you find some. Yeah. Yeah. Yes, Adrian. Hey, so you know what? One thing we haven't mentioned at all is that there was a piece of legislation that was included in the National Defense Authorization Act, which passes every year to fund the military, that is focused on creating a maternal mental health program within the Department of Defense. And so those of you who are out in the field, if you are seeing any activity in this area, if you see more emphasis on maternal mental health, on screening, on any of this, please let us know because we're anxious to hear how that program is being implemented. So let us know if you see any movement on that front. And I was just taking notes on all the different states. We have representatives from about half the states on the call, as well as folks from Whidbey Island in Washington, Fort Bragg and Camp Lejeune in North Carolina, Fort Hood, Texas, 29 Palms in California, Naval Station Lemoore, also in California. So it's great to see. Yep, Whidbey Island. Yep, living the great life out there in Washington State. Does TRICARE cover Puerto Rico? Great question. That must be on the
Yes,
east.
it
Yeah.
does.
Awesome. Awesome.
That
Yes,
might be
thank you.
overseas for Puerto Rico. It's been a while since I've thought about the state side, but I believe that is the international SOS.
Awesome. Okay. I'm also adding somebody just dropped in the chat. Somebody from Colorado is on the call. So just really great to see. I believe somebody was Germany was one of the first people who dropped that in the chat.
Now we've got Italy too.
Awesome.
Come join us
Awesome.
November 14th.
Vincenza, yay. Yay.
I know we have a screening question that's asked in here, Birdie, as well.
Okay,
So
let
you
me
and I
look
can
at it.
probably take a tackle at this one. But it says, for Birdie, if mental health is such a common complication of pregnancy and childbirth, why does it seem that postpartum depression is the only thing being screened, or are other disorders being screened unevenly? Sorry if this is not a good question. I'm a military member working to support other moms in my unit, not a practitioner.
Great question.
That's fine. You can ask that question. It's a good question.
Great question.
So on November 14th, we will go more into screening, and in our trainings, we have a whole section on screening. The Edinburgh Postnatal Depression Scale, which is the most commonly used, 10 questions, it does screen for depression and anxiety. The PHQ-9, which is probably the second most likely to be used, and they're both validated in the perinatal field, it screens only for depression. But a screening tool, as we like to say in our trainings, is only a piece of paper. So if all you're going to do is hand them a screening tool and then score it and put it in the electronic medical record and say, whoop, I got that off my checklist, then you just wasted your time and their time. We want to make sure we're asking more questions after, and that we are educating that baby blues last 2 weeks, that this is so common. This affects 1 in 5 to 7 mothers, 1 in 10 men, and you didn't cause it. It's because you have a lot of risk factors. They need to know those things when you're giving a screening tool. So the screening tool is one thing, and yes, it may not even catch intrusive thoughts. And no, you may not have time during an OB visit to do all of this, but you can start and you can add to it. You can hand them a discussion tool and you can hand them different things that they go home with. I think it scares people to find out what's really going on. Oh my gosh, what if they are depressed? What do I do with them? And they really just need to know resources. Postpartum.net. And there's a tab that says get help. So your question is, they are screening with the Edinburgh Postnatal Depression Scale. It is screening for depression and anxiety. And it's okay, the PHQ-9 only depression, but they both have a suicide question. And we just cannot ignore anything other than 0 on the suicide question should not be ignored. So that's a long answer to your question, Rebecca.
Right. And ideally the screening tool is the beginning of a conversation. It's not the end, right? And so
it's more assessment after that. And if you're not trained in the assessment, then when they have a high score, you need to know where you're going to refer them to. And they don't leave your office if they scored anything other than 0 on question number 10. And you ask more questions then. They really might not be suicidal, but you have to ask more questions. So yeah, we teach all on that.
That's
Yeah,
awesome.
Birdie and I love going over screening tools. So
Me
if you're
too.
joining us on November 14th, ooh, you're in for a treat because we love talking about it a lot.
All right, everybody, we are approaching the top of the hour. We want to be respectful of all of our participants' time. We are so grateful for all of you for taking time from your busy lives in different time zones to be with us. We know for the West Coast people, it was really early. For those folks in Europe, it was, getting close to your dinner time. So grateful to our fabulous panelists for being with us today. Again, look out for an email from us in the next day or two with all the information that we discussed, and enjoy the rest of your day. Thanks for being with us.
Thanks, everyone.